Hello, and welcome to Skin Issues Related to Pediatric Transplant. We are so happy to have you with us today. We're also very honored to be able to have presenters Dr. Karina Vivar, attending physician in dermatology at Ann and Robert H. Lurie Children's Hospital of Chicago, and Dr. Harriet Bagnal, Hinen, dermatologist and internist at Medical University of South Carolina, joining us today to help teach us a little bit about transplant-related skin issues and to answer some questions.
Hello, I'm Karina Vivar. I'm a pediatric dermatologist here at Lurie Children's Hospital of Chicago. I'm here to talk about some skin concerns in pediatric solid organ transplant recipients. I know that there are a number of conditions that can affect the skin after transplantation. I wanted to focus on just a few of these for this conference today. We'll talk about eczema, warts, and the risk for skin cancer. I hope that there's not too much repetition with Dr. Hinen's talk. So first, we'll talk about eczema. Eczema is within a group of conditions known as the atopic conditions, where there is a familial or personal tendency to develop sensitization to environmental triggers. This can include food allergy, eczema, which we also call atopic dermatitis, environmental allergies, also called allergic rhinitis, and asthma. We know that eczema can happen after solid organ transplant. It occurs because of immune dysregulation. Also, some of the medications used as anti-rejection medicines can shift the immune system towards a more allergic or atopic condition. In one study, about 14% of pediatric liver transplant recipients developed some sort of atopy, whether it was food allergy, asthma, eczema, or seasonal allergies. Half of those patients that developed atopy had eczema, and this developed at a median of about a year after transplant. Eczema can have many different looks. Can be more red, scaly, very, very itchy. That's often a hallmark. Here we can see eczema more in the folds with crusting, scale, some more redness, scaliness, crusting, scabbing, very itchy. On patients with other skin tones, darker skin tones, eczema can have a different appearance. It can be more discrete bumps, such as here. It can have hyperpigmentation instead of redness, still with scaliness, dryness, and open erosions and crusting. And same thing here. Here we can see a mix of redness, crusting, open skin, and also some darker brown pigment associated with the eczema. So what can we do to treat the eczema? We have 4 general pillars of treating eczema. Those are gentle skincare, which we will get into, topical steroids, addressing any bacterial overgrowth or infection, and also addressing the itch. For gentle skincare, things that I tell all of my patients: take short showers or baths, less than 10 minutes. Set a timer if it's a teenager who likes their really long, hot showers. Also make sure that the water is warm, not hot. Long, hot showers can lead to worsening of dry skin and therefore worsening of the eczema. Use really plain cleansers. I try to have patients avoid things with scents, fragrance, dyes, but also those with botanical or food ingredients, or extracts that can sometimes make eczema worse. Also, finally, using bland emollients, especially after a bath or a shower, but really anytime during the day to combat dry skin. In general, ointments and thick creams are better than lotions for moisturizing. This is a general patient handout that I would give to an eczema patient of mine. We went over the dry skin care, the gentle skin care, and the top part. And then in terms of medications, our gold standard are really our topical steroids. And there are various strengths or potencies of our topical steroids, and each one has a special appropriate location of where they should be used. Sensitive areas where we use lower potency, lower strength topical steroids include the face, the underarms, and anywhere under the diaper underwear area. The body, the trunk, arms, and legs can use something that's a little bit stronger. The eyelids are a special site because we don't like to use topical steroids for prolonged periods of time, as it can lead to high pressures in the eyes called glaucoma. We often have special vehicles for the scalp that are a little looser, a little bit easier to get in the scalp and around the hair. And for areas with thicker skin, like on our hands and feet, sometimes that can use an even stronger topical steroid. The topical steroids generally can be used twice a day when the areas are rough and raised. What I typically tell patients is to close your eyes. If you can feel the skin is rough and raised, you can safely use a topical steroid there without risk of side effects like thinning of the skin, pimple-like areas, or hair where you don't want it. You put the medicine on first, the prescription topical steroids, and also seal it in with a thick cream or ointment. Put the medicine only where it needs to go, and then the moisturizer can certainly go anywhere. The instructions, you'll notice, say stop when the skin is smooth. So when the skin is smooth, there usually is no inflammation there. That's when you can close your eyes and feel that there's nothing rough, nothing raised to treat. And when the skin is smooth, all you need to do is moisturize. Kids with eczema can have more bacteria on their skin, specifically one called staph, and dilute bleach baths can be a helpful way to decrease the burden of the eczema as well as decrease inflammatory markers of eczema. So sometimes it sounds pretty intimidating and pretty crazy to put bleach in your child's bathtub, but it is the equivalent of making a chlorinated swimming pool in your bathtub. It is very, very dilute and has been shown to improve eczema. Occasionally, if there is a true bacterial infection, antibiotics might be prescribed, but I would always recommend that if you are going to get an antibiotic for a skin infection, I would always recommend getting a culture first so we can see what that bacteria is that's growing. Occasionally, if the itch is so disruptive of sleep, then medicines like Benadryl or its cousin hydroxyzine might be used to help with falling asleep or staying asleep. Sometimes antihistamines may also be used during the day to help with the itch. Another big point that I want to make about eczema is that it is a chronic condition. Right now, there's tons of research being done, but there is no cure. Usually kids will grow out of this over time, but we need to manage the eczema while it's there. Again, You can stop the medicines, the prescriptions, once the eczema is improved and the skin is smooth. At that time, only use a gentle moisturizer. But I always tell families, keep your toolbox close because that eczema really may come back and probably will. Next, we'll talk about warts. Warts are very, very common. They most commonly occur in children and young adults. They're caused by a viral infection of the skin by human papillomavirus. There can be different forms of warts. The common warts can be crusty, can be bleeding, can be pink or flesh colored. There are other warts that can be a little bit more subtle, maybe brown or even flesh colored and not as protuberant, more flat to the skin. There can be warts on the bottoms of the feet, which can be very painful. And there can also be genital warts. Warts, again, they can look pink, scaly, round, or they can look filiform, like a leaf coming off of the eyelid here. They can occur under the nails, around the nails, which can be very painful and bothersome. Most of them do occur on the hands, the fingers, the elbows, and the soles of our feet. They are spread from skin to skin contact, and they can also be spread from soft materials or dust, stuffed animals, bedding, towels, things like that. They can also be spread by scratching one wart and then scratching another part of the body. That's called autoinoculation or Kebnerization. And the time from exposure to the wart to actual development of something we can see on the skin can really range from 1 to 6 months, even longer. And warts, unfortunately, they can last for several years with or without treatment. Here we can see flesh-colored bumps on the forehead, and where they are all in a line, that's what I was talking about with Kebnerization or autoinoculation, where scratching a wart can then spread it to other places where the skin is scratched and traumatized. Here are those pesky plantar warts that can be more flat or even look like they are inside the skin. And they can also be so prominent and ugly looking on the hands and feet. To get rid of warts, our body generally needs its cell-mediated immunity. Therefore, immunosuppressed patients, like our transplant patients, can have difficulty getting rid of warts, and they can have increased frequency of extensive warts, and they can be difficult to treat. Patients are also at a higher risk of neoplastic transformation or the development of cancer in warts that are caused by HPV. So there's this big range. Warts can be a harmless nuisance. They can certainly be painful. Other people can see them and they can be quite disfiguring. And they also have this risk of developing cancer. What can we do to treat them? One, we don't have to do anything. In general, they're not medically dangerous, but we know there are other reasons to treat them. So there is a long, long list. And that's because even in the general populations, in non-immunosuppressed patients, warts can be super, super stubborn. I always tell my patients, because they're so stubborn, anything that we do for warts has to be repetitive. To go down the list, over-the-counter treatments with salicylic acid are often the most successful for families if they're going the route of over-the-counter treatments, but it can be very irritating and it is also time-consuming. I tell families the goal would be to do the salicylic acid every single night, unless there's too much irritation, in which case you take breaks. And this process can often take weeks to months. Cryotherapy and manual pairing, those are things that I offer in the office, but they are unpleasant to say the least, can be uncomfortable, can be even painful. It can blister and it can scar. Trying to stimulate the immune system to fight off these warts is another approach. One thing that parents will always ask about, is there anything we can give the patient by mouth to help these warts go away? The one thing that has had mixed success is cimetidine, which is typically an acid blocker. And this is an off-label use, and it just tastes really terrible. And I have had few patients who are able to tolerate it. There are other topical medications that can be used to stimulate the immune system to start paying attention to the warts. And it's called imiquimod. This one is off-label. And all of these medications, we have to make sure that they do not interact, especially with the anti-rejection regimen. Even if medicines are put on top of the skin, we worry about absorption through the skin. And we have to worry about, therefore, interactions with other medicines, as well as any prior organ injury. If these medications are metabolized by the liver or by the kidneys, we certainly don't want to threaten the function of those. This is a video that one of my patients generously allowed me to videotape with her permission, and I told her I would be showing it at a lecture. And this is cryotherapy, where I apply liquid nitrogen to a wart in clinic. 1, 2, 3. So I typically freeze with a cotton tip applicator for about 10 seconds. It truly makes an ice ball where the wart is. We let it thaw, and then we do it again. And this patient was about 10 and tolerated it very well. So that was cryotherapy. In general, I say this is our quick and dirty way of taking care of it. It is not pleasant. It can be very painful. It can blister and it can scar. And not every patient is able to tolerate this. At home, using an over-the-counter therapy, again, I find families have the best success with a salicylic acid gel. Put it on top of the wart, you cover with the duct tape, you take the duct tape off in the morning, and you do it every single night until you think the wart is gone, and even a little bit after you think the wart is gone, to ensure that we get the deeper roots. If there are flat warts or warts on the face, the salicylic acid can be too irritating. So I typically do prescribe a different medicine, a retinoid, to do a similar job as the salicylic acid, but is a little bit more gentle. Again, this can take weeks to months to improve. And this is our low and slow method. Then someplace in the middle is salicylic acid compounded with 5-fluorouracil, which is a prescription. It's a little bit more aggressive and more proactive than the over-the-counter medicine, and tends to work really well, particularly for warts on the hands and the feet, but it is certainly more irritating than the over-the-counter stuff. All in all, for warts, I really try my best not to make the treatment worse than the problem itself. I try to avoid overly aggressive or scarring therapies, and I am not there to torture patients in clinic. So if a patient is unable to tolerate cryotherapy, I will not do it. Lastly, for warts, I do want to talk about the neoplastic or malignant transformation. So we know that there are HPV vaccines out there that are FDA approved and are proven to be effective in preventing cancer that is associated with HPV. So what can it do for warts, these HPV vaccines? There are case reports, small case series, and some anecdotal reports using HPV in particular to treat flat warts, plantar warts, or common warts. Some of these cases have the HPV vaccine injected right underneath the wart to stimulate the immune system. And some of them are just giving the HPV vaccine standardly inside the muscle, just like a normal shot. And even if the HPV strain most associated with common warts are not specifically targeted in these HPV vaccinations, they can still be effective in taking away these warts. So HPV vaccination is recommended before or after solid organ transplant. It really is recommended for the prevention of HPV-associated cancer, but it can also help with warts. So I really, truly do recommend it in all my patients. Lastly, we'll talk about the risk of skin cancer in patients after solid organ transplants. Most of our data is from adults. So in adults, this skin cancer is the most frequent cancer after solid organ transplants. Skin cancer has many different types. They can be non-melanomatous. Those are our basal cell and squamous cell carcinomas, melanoma, which is one of our more worrisome skin cancers, Kaposi sarcoma, and our anogenital carcinomas. About 50% of Caucasians, adult solid organ transplant patients, do develop basal cell carcinoma and squamous cell carcinoma. In adults, squamous cell carcinoma is the most commonly developed skin cancer. And this is at a very high rate as opposed to the general population. The incidence of squamous cell carcinoma is anywhere from 65 to 250 times as great as in the general population in adult solid organ transplant recipients. For basal cell carcinoma, it's about 10 times as great. We don't have as much data in pediatric transplant recipients as in adults. There have been a few studies. All of these studies have shown that pediatric organ transplant recipients had a higher incidence of all cancers across the board than the general population. And all of these studies did show that there's a higher incidence of skin cancer in particular in these pediatric solid organ transplant patients than in the general population. And it accounts for a good amount of the cancers in this population. In solid organ transplant recipients, skin cancers can be more aggressive. They can lead to decreased quality of life, and they can have more morbidity and be more fatal. The risk factors include the intensity and duration of immunosuppression. The immunosuppression can also impair DNA damage repair, and transplant recipients also have a higher infectious rate with these oncogenic viruses like HPV, which does play a role in the development of skin cancers. Other risk factors, having fairer skin and also having cumulative sun exposure that's high. What do our skin cancers look like? They can look like red bumps that are scaly. They can look more pronounced and dangerous. Here's one on the lip of a child. Almost looks like a wart, to be quite honest. They can look more flesh colored, but with some vessels overlying, a little bit of scale, maybe a little pearly. This one is very subtle, almost flesh colored here. They can almost look like a scar, another pink bump, or they can look dark like a mole. So in the pediatric solid organ transplant patient population, for those that do not receive kidneys, it's the second most common malignancy. The first most common is post-transplant lymphoproliferative disorder. In pediatric renal transplant recipients, non-melanomatous skin cancer is the most common cancer. So those are squamous cell carcinomas and the basal cell carcinomas, which I showed pictures of just now. In pediatrics, there is an increased risk for skin cancer, and that might occur 10 to 20 years after transplant. And the average age of the patient, therefore, is around 26 to 34 years. So the transition from a pediatric dermatologist to an adult dermatologist is really essential, as 20 and 30-year-olds truly don't go to the doctor as much as they probably should. Just like in adults, squamous cell carcinomas are more common than basal cell carcinomas, but at a less high rate. There are lots of considerations for types of immunosuppressive medications used, and choosing one or the other is truly up to the transplant team. But we do know that some of the anti-rejection medicines can lead and contribute to skin cancer development. For example, azathioprine, mycophenolate, they can contribute to UV-mediated mutations in the skin cells and also be photosensitizing, leading to more sunburns, which we know can increase the risk for skin cancer. Also, cyclosporin, tacrolimus can contribute to the risk of squamous cell carcinomas, one of the more common skin cancers and the most common skin cancer in the post-transplant patient population. On the other hand, the mTOR inhibitors like sirolimus and everolimus may reduce the risk of skin cancer in transplant recipients. Another medication I want to highlight is voriconazole, which is used particularly in lung transplant patients to prevent invasive fungal infections. We know that voriconazole is also photosensitizing, so making patients at risk of developing more sunburns, also aging from the sun and damage from the sun, but also prolonged therapy greater than 6 months can be associated with the development of squamous cell carcinomas. Anogenital cancers, so cancers of the anus, around the anus, and the genitals are the third most common post-transplant malignancy in pediatric solid organ transplant recipients. And it is more common in girls than in boys. I bring this up to bring it to our attention, but also to advocate that when your children see a dermatologist, to encourage them and reassure them that we are taking care of all of their skin, no matter where it is, even in the private area. And I know it can be very awkward and embarrassing, but we do need to look under the bra, under the underwear, because we have skin everywhere. And anogenital cancers are very prevalent in the post-transplant patients. One of our more scary skin cancers is melanoma. It does occur more often in pediatric solid organ transplant recipients than in the general population, but luckily the total number is small. So the relative risk of melanoma development is about 4 to 5 times as high as in age-matched populations. And luckily, only about 4.4% of pediatric solid organ transplant patients developed melanoma. So that's a very small percentage, but it still is higher than the general population. In another study, about 50% of post-transplant melanomas occurred in childhood, and 25% of them were fatal. Melanoma is thought to be associated with the development of excess moles. Here are some appearances of melanoma, though it can take on many faces: red, pink, large, with some darker pigment within it, irregular, or this one up top, it is pretty symmetric in shape. So how do we find these melanomas? Generally, we think of the ABCDEs of moles. Moles that are asymmetric, have irregular or changing borders, have two different colors to them, or are irregularly colored or have changing colors. Moles that are greater than 6 millimeters, which is about the size of a pencil eraser on the end of a pencil, or moles that are changing. Those are signs that the mole could be worrisome and should come to the attention of a doctor. In childhood melanomas are different. And so a different ABCD has been proposed. A for melanotic, meaning pink. It's not always dark brown or black in pediatric population. They often bleed and look more like a bump, whereas adult melanomas can be flat. Color uniformity, before I talked about irregularity, but color uniformity with a pink mole can also be worrisome. And childhood melanomas can develop out of nowhere, not from an existing mole, but just by itself. And they can truly be any diameter, not just greater than 6 millimeters. How do we treat skin cancer? Usually, simple excision is all that's needed with adequate margins. However, if the skin cancer is more aggressive, as it can be in patients that are immunosuppressed, lymph node dissection might be necessary to see if the skin cancer has metastasized. And then if it has, chemotherapy, radiation, and other new targeted therapies might be employed. What we really want to do instead of treat skin cancer is prevent it. And a large part of that is sun exposure and preventing sunburns. So about 40 to 50% of our lifetime sun exposure occurs by 20 years of age. So these are the decades usually where kids are living under your roof and you have more control over it than when they're in their 20s or 30s. This is the time to lay the foundation for excellent sun protection habits. So number one rule would be avoiding exposure during the bright sun hours. So anywhere from 10 a.m. to 4 p.m. Sun protective clothing is truly the best. You don't have to reapply sunscreen every 2 hours if you're already wearing sun protective clothing. Hats, sunglasses, like you can see here, and for areas that are exposed, sunscreen. Some other photos of sun protective clothing. We always joke in dermatology that the left is how all of our babies look when we're at the pool, and you can always spot a dermatologist child. So what type of sunscreen should you use on those exposed areas? The mineral blockers are typically the best, and they are the least irritating. So our physical blockers, mineral blockers, they're also called, are the zinc oxide and titanium dioxide sunscreens. The chemical sunscreens, all these names that is so difficult to pronounce, those are the ones that are typically very irritating, especially to kids with eczema, like we talked about before. This is one of our handouts from the Pediatric Dermatology Society that outlines our handouts, and our sunscreens, and I'll talk more about the Society for Pediatric Dermatology later. So in pediatrics, there are no formal skin cancer screening guidelines. In adults, they recommend screening every single year and modifying that depending on individual factors. So typically, I would recommend at least an initial screen with a dermatologist after transplant and just decide on an appropriate course of action depending on the moles that are there, depending on other risk factors, maybe monitoring every 2 years, every year, maybe every 6 months if there are worrisome moles, but at least having that baseline screening to have that discussion is important. Self-examination, the pediatrician can also help with that. They are excellent at telling us when they are worried about moles. Sometimes, if patients do have skin cancers, we do need to work with the transplant team on adjusting the level of immunosuppression, considering which agents are being used as anti-rejection medicines, and considering their antifungal therapy. Since HPV infection is a risk factor for squamous cell development, HPV vaccination, again, is recommended for all pediatric solid organ transplant recipients. In the adult population, adult transplant recipients, if they've had problems with recurrent or aggressive skin cancers, sometimes there are medicines that we can give to help prevent this, but it's not yet established in children. So just to review some take-home points, eczema is very common after a solid organ transplant. It is a chronic condition that can be managed with avoiding dry skin and using prescription medicines when needed. Warts are common and they are very stubborn. If treatment is wanted, the treatment needs to be repetitive. It should not impact other organ systems, should not interact with other medications, and certainly should not be too painful or distressing to the patient. HPV vaccines do prevent HPV-associated cancers and may also be helpful in treating warts. Finally, solid organ transplant patients are at a higher risk of developing skin cancer. If they do, it occurs 10 to 20 years after transplant and can be more aggressive than in the general population. Prevention of skin cancer includes diligent sun avoidance and sun protection. So I said I was going to talk about the Society for Pediatric Dermatology, which is our North American society where we congregate and have all of our pediatric dermatologists. It is a really great resource for patients as well. This is our website here, but I wanted to point out a specific functionality of the website, which is find a pediatric dermatologist, because I know you don't all live in Chicago. So you can search by the zip code, you can search by your city, or you can search by state. And this will give you a list of all of the board certified pediatric dermatologists in your area. This is a picture of my mom and my puppy. My mom just had her 6-year anniversary of having her kidney transplant. She was part of a swap that had 4 recipient and donor pairs. And these are the 4 donors that donated their kidneys to my mom and 3 really fortunate recipients. So this is who this lecture is dedicated to here. So thank you for listening. I hope I have answered some questions and some concerns. Here's a list of my references, and I hope you have a great rest of the conference.
Hello, my name is Hinen. I am Pediatric Dermatology Fellow at the Medical University of South Carolina, and I'm really excited to be talking with you guys today about different dermatologic considerations in pediatric transplant patients, specifically talking about why the role of dermatology is important in transplant medicine and some different consideration, and also to talk about some different cases in pediatric dermatology as it pertains to transplant. So first question is, what is a dermatologist? And if you Google dermatology, these are some of the images you might find, and kind of portrays what the media sees dermatologist as. And so a lot of what the media thinks dermatology is more cosmetic concerns, so injections, lasers, rejuvenation, things like that. And a lot of you have probably heard of Dr. Pimple Popper, who's a dermatologist that is famous and has a show and has really brought attention to kind of more the medical aspect of dermatology. But still, the show kind of focuses on particular skin problems that are easy to fix. So, excisions of skin cancer, cysts, things like that. But she has mentioned wanting to bring more awareness to some of the more chronic skin concerns, which makes up a lot of dermatology. So a lot of dermatology, focuses on skin conditions that can't be cured right away and have to be followed over time. So today we'll define that a little bit more and kind of the role of dermatology as it pertains to transplant specifically. So first of all, I do think it's important to know kind of what a dermatologist is, because there's a lot of different specialists out there who treat the skin. But it's important to know what a board certified dermatologist is, so that when you're looking for a provider, especially in the setting of having a transplant and having more of a complex medical background, you want to make sure you're seeing somebody who's been trained specifically in dermatology and has the highest level of training. And so to become a board certified dermatologist, one needs to complete an undergraduate degree and then do 4 years of medical school. You then do 1 year of internship, and this can be in any sort of basic medical specialties such as pediatrics, internal medicine, surgery, or family medicine. And then after that year of internship is complete, you do 3 years of specifically dermatology residency, which is just training on hair, skin, and nails. So this comes out to be like 16,000 hours or more of just learning about the skin. And once you complete these 3 years of dermatology residency, you are eligible to take a board exam and become a board certified dermatologist. So when you're looking for somebody to see, you want to see that they have the letters FAAD after their name. And this indicates that they have passed their board exam and have the highest level of training in dermatology. After that, you have the option, you don't have to do a fellowship, but a lot of people choose to do kind of a year of additional training, just kind of within dermatology to be subspecialized. So like for me, I'm doing another year of pediatric, specifically dermatology. And some people will choose to do Mohs, which is surgical dermatology. Some people focus on pathology, which is the microscopic side of things. So examining biopsy slides and things like that. And then there are some others as well. If you have more questions about this, or if you want to find a board certified dermatologist near you to provide care for any skin questions, or just to, kind of establish care, you can go to aad.org. And they have a great patient resource page to help you kind of find somebody near you, and also just further define, what a dermatologist is and what you're looking for when you are searching for a provider. And so dermatology as a specialty really is more than just skin deep. Dermatologists are trained, in over 3,000 different types of hair, skin, and nail disorders. And a lot of these disorders aren't just really localized to the hair, skin, and nails. They can be reflective of kind of underlying processes going on inside of the body. And so as dermatologists, a lot of things, some of the common things we focus on are going to be like skin cancers and screening for skin cancer. This includes melanoma and other less common skin cancers. Also different autoimmune and inflammatory conditions. This includes things like eczema, psoriasis, hair loss, and then we treat all different types of skin infections, and we'll dive into that a little bit more here later. And then we do also focus on cosmetic concerns too, so treating scarring, photo rejuvenation, those types of things. So we really do anything and everything when it comes to the hair, skin, and nails. And so one different question you might ask, is why should you see a board certified dermatologist? So somebody who specializes in the skin and has a high level of training and recognizing hair, skin, and nail disorders. One reason would be if you have a complex medical history, because the skin findings oftentimes reflect underlying systemic diseases. And a dermatologist is really trained to kind of help tease these out and get to the root of the problem if there's something kind of bigger going on than just the skin. Also, if there's a history of immunosuppression, and so this really, is pertinent for patients who have had transplants, because if your immune system is compromised, a lot of things on the skin, even common things, can look differently. And so you need a specialist to be able to kind of see exactly what's going on and get the diagnosis right from the beginning. And then also treatment can be difficult, management can be difficult when you're working with, patients with a complex history and who are on lots of medications. And so dermatologists can help you with that. Also, other reasons to see a board certified dermatologist is for skin checks if you have a family history or personal history of skin cancer, or if you've just had a lot of sun exposure over time. If you have particular cosmetic concerns, they can be helpful. But really, it boils down to any skin concern you have, a dermatologist can help you. So specifically pertaining to transplant patients, there's lots of different things dermatology can help with. The first of these would be yearly full body skin exams to monitor for skin cancers or other problems. And so there's a couple reasons why this is important in transplant patients. Number one is they have a suppressed immune system a lot of the times. And so this can put you at increased risk for developing skin cancers. And then sometimes some transplant patients are on medications that can cause increased sensitivity to the sun. And so that can also make you at increased risk for skin cancer. There's also a lot of different rashes that can be seen in transplant patients. Some of these include graft versus host disease. They're also more likely to get things like eczema and viral rashes, drug rashes. And so we can help kind of figure out what's going on. Transplant patients are sometimes also at increased risk for autoimmune conditions like psoriasis and hair loss, and these are conditions that we frequently treat. And then the other category that we're going to focus on, and I'll show you some kind of interesting cases on later, are skin infections. Viral warts being the most common skin infection in transplant patients, bacterial infections, ringworm infections. And so these are all more common in transplant patients because they have a lower immune system. And it makes it a little bit more difficult or more challenging to treat these problems. So, sometimes we have to get a little bit creative and try lots of different things. The risk of these different skin conditions actually varies. Just because you've had a transplant doesn't mean you have the same risk as somebody else who's had a transplant. And so the risk kind of depends on what type of transplant you've had. Is that solid organ or hematopoietic stem cell transplant? What type of solid organ, things like that. A lot of that plays into the degree of immunosuppression that you have. And then if you're on any antimicrobial prophylaxis after transplant, so if you're on long-term antibiotics or antifungal medications, these can affect your risk as well. So like we talked about, transplant patients are going to be at an increased risk of skin infections because of the immunosuppression. And infections can be a little bit tougher to diagnose initially in transplant patients because sometimes common infections look a little bit different. Also, rare infections are going to be more common in immunosuppressed patients. And infections can play, sometimes they can be a little bit challenging to treat, like we talked about before. And dermatologists can really be helpful to help, get the right diagnosis and then also come up with some different treatment options to eliminate those infections. So next, we're just going to kind of go through some different cases that we've had at our institution of patients with history of transplant who have had infections and kind of what we did to manage those and just showing why it's important that they see a dermatologist. So this first patient is one who had a history of a kidney and a liver transplant many years ago. And they've been seeing us for a while and presented over the years with a couple of different common skin conditions. And so the first are going to be warts that they had on the hands, legs, and face. The ones on the hands were actually pretty easy to recognize as warts, and I think most providers would recognize them as warts. But then they had flat warts, which is like a particular subtype of warts on the face and legs. And I'll show some pictures, and you may see why it would be hard to tell, whether that's a wart. And so we were able to diagnose it and treat accordingly. And then they also had acne, and then a while ago had history of ringworm infection as well. And all of these things are common skin complaints in transplant patients. So as you can see in this picture, the wooden part of the Q-tip is pointing to this kind of yellow skin-colored bump on the side of the face, and they've actually got another one right above it. And it's pretty subtle, but they were definitely bothersome to this patient. And just kind of looking at it, a lot of people might not think it's much of anything, but these actually were flat warts. And so treatment can be a little bit difficult with these. I'll show you another picture right here on the side of the nose. The arrows are pointing to two other little skin-colored bumps that were also flat warts. And so we had to take into consideration a lot of different factors, and ultimately these were successfully treated with laser. And so we were able to eliminate those flat warts on the face so that we didn't have to do anything like scarring or anything too painful. And then this was the same patient with warts on kind of around the fingertips. And actually in this picture, they had a good bit of irritation from some of the over-the-counter or topical treatment that they were using. And so we kind of have to balance any sort of treatment reaction to effectively treating skin lesions. And so this case I present because there's a couple different considerations and challenges. So a lot of the different treatments for warts and other viruses that we have rely on a fully functioning immune system. So we really have to focus more on destructive type methods for warts. And we also want to choose appropriate medications because in this patient who had had a kidney and a liver transplant, we have to make sure we avoid any medications that could potentially harm the kidney or the liver. And then in many transplant patients, they're on other medications, so we want to make sure we avoid any sort of interactions. And then I think another really important part of treating transplant patients, which we do a lot, is kind of talking with the patient's other doctors, because there's usually kind of a whole care team involved. This patient has a liver doctor, a kidney doctor, so we needed to talk with them to be able to choose appropriate therapies, not just for the warts, but also for the acne and other things, because we want to treat the skin problems, but also not cause any other problems along the way. So this next case is going to be a patient who has a history of a heart transplant and eczema. Eczema is a common skin complaint among transplant patients. And they actually developed molluscum contagiosum, which is a viral infection, as well as warts. And this is a picture of the molluscum when we first saw this patient. And as you can see, there's lots of little pink bumps all over the belly and the thighs. And this is a picture of a wart that was on the finger, and there were several others like this on other areas of the body as well. And so molluscum is another common viral infection in kids. Most kids will end up getting a molluscum infection at some point in their life, but in kids who haven't had a transplant, it may just be a bump or two and it kind of goes unnoticed. Usually these spots only last about 18 months and then they kind of go away on their own, but sometimes they can last for much longer and be very extensive. Particular risk factors in this patient for having a bad molluscum infection were the eczema and then also the immunosuppression. So we had to work with both of those problems to get the molluscum to clear. Just like with warts, treatment of molluscum is oftentimes we use the immune system to kind of help spur the immune system along to recognize the virus and clear it on its own. But this is harder in immunosuppressed patients, so we have to do kind of some other different treatments that aren't as common. And sometimes, these can be painful. And so we work with other doctors to treat while patients are under sedation for other types of procedures. And this patient, we were able to treat them while they were under sedation for cardiac catheterization. So they didn't have to go through any painful procedures awake. And in this patient, we have been, helpful in reducing the number of bumps that they had. But the infection really has been going on for many years at this point, and we just have it under good control and are still working on getting that infection clear. So this next case is another patient with a heart transplant, and they, after their transplant, developed severe eczema and molluscum infection, just like the previous patient. This is a picture of those molluscum bumps on the forehead. And then these are similar molluscum bumps on the back of the wrist, and you can see they're really, really angry looking and kind of crusted. So in this picture, they look a lot different than the other patient's molluscum, which is pretty common actually to kind of see, people have the same virus, but it presents differently depending on the history and the patient. And this is a picture of their eczema as well. And as you can see, there's a lot of broken skin. And this makes it easy for viral infections to get into the skin. And since they don't have as good of an immune system, it can be a little bit more difficult to treat and easier to get infected. And then the next case is a patient who had a heart transplant who got an extensive infection with warts and developed a skin cancer within that lesion. And so this is a picture of the forehead in 2019. And they were actually lost to follow-up for a little bit and were following in a different city. And so it progressed to this over time, which was biopsied and came back as a skin cancer. And so that just kind of goes to show why it's really important to follow along and treat skin problems while they're still really small before it becomes a bigger problem. And so in summary, dermatologists are specialists that are trained in the diagnosis and management of over 3,000 types of hair, skin, and nail disorders, and are really an important part of a care team for transplant patients. And I think it's really important that patients who have had a transplant are at least established with a dermatologist. So if a skin problem comes up, they can get an appointment and be treated appropriately from the beginning. Common skin conditions can have kind of atypical presentations in transplant patients. And so it's important to have somebody who can recognize all the different ways that some different skin conditions present, and also know different ways to treat it. And then it's really important to take into account a patient's overall health history when you treat skin disorders. And it's important to make sure that your doctors are talking with each other and that we're kind of taking care of the patient as a whole and not just focusing on one body system over the other. And these are a reference. So thank you for listening today.